And we get started. Good morning, or I guess good afternoon, everybody. This is Ed Crowe. Thanks for coming on today. I know we have a different start time today. We're 12 o'clock today. We're going to be 12 o'clock on Thursday as well, just because of scheduling reasons. So I'm sure that's going to throw a few people off, probably because we usually do 1 o'clock. But we'll get started here. I imagine this presentation will probably go about 20 minutes. So today we're going to talk about the Medicare prescription payment plan. Before we do that, though, a couple things. When we get started, I always say these things. We do record these webinars. We will send you out a copy of the recording if you registered. So even if you don't attend, you'll get a copy of the recording emailed to you. Also, you can go on YouTube. So go to youtube.com/@Crowe Medicare. We put all our recordings up there. So every webinar we've ever done is up on YouTube, so you can watch them whenever you want up there on the YouTube channel. If you have questions, please send them into the question section. Send them in whenever you want. I will answer them at the end when we're done, so in about 20 minutes, give or take. And if you want, send them in during the webinar. Sometimes people, I think, are sending them in at the end, and I've been told that I end the webinar abruptly. So I'll try not to do that today, I promise. And with that, let's get started. So here's what we're going to review today. We're going to go over the program. So this is the Medicare prescription payment plan. We're going to go over that. We'll go over how it was created, what it means for the member, what the agent's role, our role is in this, which really isn't that involved other than just to tell them about it and understand it. What the carriers think about it. I'm making some assumptions there, but we'll talk about probably their take on this. As I mentioned, all our webinars are recorded, that you can watch them on the YouTube channel and then send in questions at the end. Okay, so the Medicare prescription payment plan was created by the IRA, the Inflation Reduction Act. So how the Medicare prescription payment plan reduces inflation, I do not know, but it was part of that legislation that created it. It starts January 1st, 2025. And the general idea of this thing is members, so your Medicare members, are allowed to pay their out-of-pocket costs over the course of the year, of the plan year. So plan year with Medicare, as you know, runs January to January. So it basically, whatever they have out-of-pocket for copays, not premium, but whatever they have out-of-pocket for copays, it spreads it out over the course of 12 months, 9 months, depends on when they opt into the program, because they have to opt into the program to use this. It's not automatic for them. People can opt in prior to the start of the year, so they can opt in before January 1 to the program, or they can opt into the program anytime during the year. So if they opt in to the program, let's say they go to the pharmacy and they decide then in March to opt into the program, and the pharmacy says you owe us a ton of copays, they can opt into the program and they pay the pharmacy nothing then once they opt in. Or if they know about this program, they can opt in prior to the year starting. So this program is applicable to both standalone PDP plans and to any drug coverage in an MAPD. And again, if you have questions, please just send them in and I'll answer them at the end for you. So we're going to keep the general idea theme going here. This program does not include premiums. This is just their out-of-pocket, deductibles, copays. As you know, this year there's a $2,000 out-of-pocket max, but anyway, any out-of-pocket they have applicable to that $2,000, which they're eligible to spend, they could use this program for, but again, not premiums. This is also not applicable to Part B, as in boy drugs. That's important. So if somebody's getting a B drug, does not apply to this. That goes to their medical benefit, and they can't use this prescription payment plan for a Part B drug. How does the notification work? So the notification means the carriers must notify the members via multiple methods, and that was built into the legislation. CMS did they did an update on this, and then they did a second one where they clarified a few things. So the carriers have to send the members a notice by mail. They must communicate this program to members via a number of means: website, explanation of coverage, the ANOC letter, and there's other ways they had to do it too. I got bored reading it, so I quit reading any further after that. But I think there are more. I just, guilty as charged, didn't read any further into it after that. So carriers must also automatically notify any members again if they spent at least $2,000 the previous year. So if they had $2,000 out of pocket the previous year, they get an extra notification just even before the year starts of this program, because they look at their past spend on drugs. If the person goes to the pharmacy and they're projected to spend $600 or more on a single script, the carrier must then notify the pharmacy. The pharmacy will then give the member a brochure or a notice explaining the program and letting them know they can opt into the program, and when they do, they will not have to pay anything at point of sale, that they then would be opted into the program. So again, person opts in, they go to the pharmacy, pharmacy says you owe us whatever amount of money. Person says, I'm going to opt into this brochure, I'm going to opt into this payment plan, then the pharmacy collects no money from them. The way this works behind the scenes is the carrier then needs to pay the pharmacy up front for the costs. So pharmacy collects nothing from the member, carrier has to pay the pharmacy to make them whole, and then the person's enrolled in the program. And at that point then, the carrier needs to bill the member to get the money from them. So carrier's out of pocket here, member's not out of pocket, the pharmacy ultimately isn't out of pocket because the carrier is going to pay them. And then the carrier has to bill the member and hope the member makes the monthly payments to get whole. Okay, as I mentioned, the carrier has to they have to have multiple avenues. They have to promote this to the member and make them aware it's available. And they also have to have multiple avenues for the member to opt into the program. It's going to look different by carrier. So, but they have to have at least 3 options to opt into it. There's timing with when the carrier has to have the person enrolled. So if it's prior to the start of the plan year and the member requests to be enrolled in this program, they have to be enrolled within 10 days if it's prior to the plan year starting. Now, if it's during the year, the member can request to be enrolled and the carrier has to enroll them within 24 hours. We'll see how that goes. I'm really not sure how that's going to happen, but that's the way it's written in the legislation, and that's what the carriers are supposed to do. Disenrollment and people not making payments. So the first iteration of the program that came out from CMS and through the IRA, because CMS provided clarification on it, it said initially the carriers could disenroll members if they didn't pay the monthly invoice, which the carrier is responsible for sending. And if the person didn't pay it after 2 months, the carrier could disenroll them. That has been changed. So the final version does not allow that. So in other words, members can sign up for this program. Carrier has to pay the pharmacy. Carrier bills the member. The member cannot be disenrolled for not making payments. Remember though, payments are out of pocket. If the member doesn't pay their monthly premium, that doesn't change. The carrier can disenroll them then. But if they don't pay on their payment plan for their out-of-pocket costs of the carrier, they can't be disenrolled. The Medicare prescription payment plan, which people call M3P, is only for out-of-pocket drug costs, not premiums. Okay. Here's a key one. Let's say the person doesn't pay their money on the payment plan. They just decide not to pay it. The carrier can't disenroll them, and they also cannot send them to collections. And further, they can't deny them future enrollment for owing a past balance. In other words, there's basically no way for the carrier to recoup the money. So I would assume, to answer my question I put on there earlier, I'd assume the carriers really like this new M3P. They're probably big fans of it, I would think, and I'm being sarcastic. As far as re-enrolling in the prescription payment plan, if somebody owes money from the previous year, they are supposed to be blocked from using this plan the following year. So really, in other words, they can use it for 1 year. There's really no recourse against them. It's almost a freebie, but they are supposed to be blocked from entering the program again if they owe money. Not blocked from getting in a plan, not getting kicked out of a plan, but just blocked from doing the prescription payment plan again. Okay, so hopefully that's fairly clear. I'm not sure if logistically how much sense it makes, or if, obviously it favors the member in the pharmacy, not the carrier, to a great extent. But let's just do a reminder about the drug benefit in 2025 as well, because obviously they all go together. So remember, for 2025, totally different. It's the deductible phase. You got $590. Then you got the cost share phase, the copay phase, which you'll notice on most of the drug plans for standalone PDP and Advantage, it's going to be a lot of percentages this year instead of copays. But once that member gets to $2,000 out of their pocket, premium doesn't count, but just out of their pocket, then they are capped. That's the most they can spend. And it's that easy. So you got the deductible, then you got the copay phase, which is going to really be a co-insurance phase in most cases this year for 2025, capped to $2,000. There's a big shift in cost here. Medicare is going to go from paying roughly 80% of this cost to paying 20% of it for brand drugs in 2025. So a huge shift from Medicare paying 80%, shifting it then almost completely over to the carrier. So the carrier has had a huge change in, going from paying 20% towards brands to paying 80 basically. So huge cost item for the insurance carriers. On generics, it's going from Medicare paying 80 to them paying 40. So again, a big cost shift for the carriers here. So the carriers will be taking on all this extra cost. What's this going to lead to? Well, I've talked about this in previous webinars. I started talking about this a couple months ago. It's going to lead to large premium increases in standalone PDPs. So don't be fooled by the 6% cap. I know everybody has read about that, and I did too. Oh, there's a 6% cap on premium increases. Well, that's only on the base premium. And most of these plans are, a substantial portion of them are the supplemental portion of the premium, and that has no limit. The carriers can increase that as much as they want. So what you're going to see is drug plans that maybe in 2024 are 0 or 50 cents or $1. You're going to see them in the $40, $50 range. You're going to see plans that are currently $30, almost double in the premium. So premiums on standalone drug plans are going to go up substantially. The 6% really it doesn't have any impact on that. Question is then, what will the carriers do on MA? I should have written MAPD there. What will they do on Medicare Advantage plans? Are they just going to tweak the drug plan because it's capped at 2,000? No, they're going to do more than that. It's going to impact every part of a Medicare Advantage plan. You're going to see big increases in out-of-pocket. You're going to see less extra benefits. We're already starting to see it. There'll be a reduction in the footprint of where they offer plans. So you're going to fully expect service area reductions, meaning, not going to offer the plan in these given counties this year. Some carriers have already kind of made us aware of that. One thing that's a giveaway for this is on the Pinnacle website, the pfsinsurance.com website, we put the benefits, the first looks up there. And if you've noticed, the first looks that are up there, usually the first look gives you all kinds of a look at what the benefits will be for the coming year. This year, the first look doesn't tell you anything. It's just very generic, doesn't have any benefits in it. That's a bad sign. I've been doing this a long time, and I can tell you the fact that they're not showing anything in the first looks isn't good. That's why they're just making them very generic. And again, you're going to see reduction in where plans are being offered in the counties they're offered in. And that is simply to make up for the $2,000 cap and this big cost shift of who pays the money going from Medicare to the carriers. So I wrote it here, people always ask me, what do I think of the $2,000 cap? And here's my answer. I wrote, the needs of the many outweigh the needs of the few. Yes, I got picked on. I was a Star Trek nerd. I'm not a Trekkie though, but I did watch a lot of Star Trek as a kid. I certainly don't watch it ever now. Well, I'm lying, I do, but anyway, go ahead, you can pick on me, that's fine. But Spock said on Star Trek, the needs of the many outweigh the needs of the few. Anyway, in this situation, it's kind of the opposite with the drug cap. It's the needs of the few is outweighing the needs of the many. And the reason I say that is because about 9% of people take name brand drugs. A little less than that will hit the $2,000 cap, and everybody else is going to pay for it. So certainly this is a great thing for a small percentage of people, but the masses are the ones who are going to suffer for it. So there's good and there's bad. And I am done. I'm going to see if we have any questions. Remember, if you registered, we will email this out to you, but you can always just go watch it on YouTube. I wrote on the bottom, smash that subscribe button. That's what cool people say, and that's what I'm supposed to say so we get more subscribers. So there, I said it. And let's see if we have any questions. Somebody said, so beneficiaries can enroll in the program at the retail pharmacy. That's a great question. They're going to be notified of the program at the retail pharmacy. And it depends. I've heard that there will be some pharmacies that actually can enroll them. The pharmacy can actually enroll them in the program. I'm not positive about that. I know they will have multiple options to enroll. What I've been told is it seems more like the pharmacy is going to make them aware that they can enroll, and they can enroll online, over the phone, various ways. Somebody said, what is a Part B drug? A Part B drug is a drug that goes through the medical benefit. And usually what identifies it as a Part B drug is, there's two pieces to this. The person, when they go to the provider is putting that drug in them. So you go to a doctor's office, you go to a surgical center, you go somewhere like that, they have a drug waiting there for you. They put that drug in you. That's a Part B drug, but there's two components. They administer the drug in you, and also the drug has to be waiting there for you. You got to be careful here. Sometimes now they have people go to the pharmacy, pick up a drug, and then the physician administers that drug in them via a shot or an IV. That often can fall under the regular drug benefit because they picked it up at the pharmacy. Hopefully that answered your question. Somebody said, I assume the payment schedule gets changed if medications are added or deleted during the year. Yes. How that will be administered and how smooth that will be, your guess is as good as mine. But yes, that is the idea. Regarding the $2,000 cap in 2025, does that include the deductible? Yes, it's just $2,000 out of pocket, regardless of how it's coming, whether it be deductible or copay phase. $2,000 cap does not count the premium. What if the beneficiary does not make the monthly payments? Will they still keep their insurance? Yes. They can't be disenrolled for not making their monthly payments. Now, if they don't pay their premium, then they can be disenrolled. But if they don't make their payments on this prescription payment plan, they cannot be disenrolled, and the carrier cannot send them to collections. And the carrier also cannot deny them future enrollment in a plan as a result. So, in other words, they have no way to recap the money, really. Somebody said, this is going to probably be a disaster, but would I expect anything less coming out of, well, I'll leave that part out. That's a statement, not a question. Yes, and yes, I tend to agree this probably will be pretty rough. Hard for me to deny that. I don't think this is going to go all that smoothly. I think there'll be a lot of questions. I think there'll be a lot of technical and administrative problems with it. Somebody said that's wild, that's how they're doing it. Yes, it is. I agree. Somebody said, I would assume that the carriers are going to be raising premiums big time. Yes, they are. And again, they're not capped at the 6%. Do you think carriers may be moving more drugs to tier 3 and tier 4 to increase co-payments to members? Yeah, I do, and they are. They're going to make, a lot of carriers are going to make tier 3 and especially tier 4 a co-insurance tier. You will certainly see a lot of jockeying around of drugs on the formulary to take advantage, so to speak, of that. And I think the carriers probably are going to try to get as much of that $2,000 out of the member versus themselves, because once they hit the $2,000, then it's a majority of that cost is on them. Somebody said, so if a member fails to make payments, will the member continue to get prescriptions for the rest of the year? Yes, they will. This is a popular question that came from Bill. Bill, thanks for bringing it up. I probably would have forgotten to mention it. How will this affect employer credible coverage for employees 65 or older? So the question Bill's asking there is under 65, well, it's not exactly your question, but it brings up a great point, credible coverage. So under 65, right, or if you're, as Bill said, if you're 65 or older, but you're on an employer plan, is that coverage still going to be considered credible? CMS already came out and said, yes, for 2025, it absolutely will be. And I don't think there's any way they're going to change the credibility criteria for under 65 plans for people, over 65 with credible coverage. I don't think they'll change it. There's no way they can have it conform with the $2,000 cap. But anyway, they've come right out and said they're not going to do anything for 2025 anyway. They're still evaluating it. but I don't anticipate any big changes there. I think your people who are over 65 and working still on an employer plan, I think the criteria is likely going to be left the same or nearly the same. That would be a disaster if they said employer plans to be credible had to have a $2,000 cap. It's just not going to happen. MAPDs have deductibles added now. Yeah, I mean, I think you're just going to see a lot on the, especially on the drug benefit. I've already have seen it behind the scenes. Medicare Advantage plans that don't have deductibles on their drug tiers will certainly be adding them, a lot of them. Somebody mentioned WellCare is already pulled out of 6 states. Yes, you're going to see a lot of that, not just limited to WellCare by any stretch. Okay, let's see. I got a call from a med sup client yesterday, ARP UHC. Her premium is going up 15% when typically in the past UHC med sups in New York State typically go up 7 to 8. Yeah, I don't know if those two things are related. The med sup going up. I'm not so sure that's related to the Part D piece, but because technically that's not supposed to be factored in, but it might be factored in. Okay, what else do we got? So we got a lot of questions, so this is good. Okay, so if a customer is paying $600 or more for drugs, they are just notified about the M3P and not auto-enrolled into it. I thought I read somewhere customers are auto-enrolled if they're taking expensive meds. Yeah, that initially was how it was listed, that they would be auto-enrolled, but I don't think that's going to be the case. It may be, I don't know, but there wasn't any direct clarification on how that process is going to work. But yes, that was in the initial language. It was backed off a little in the final version, but we'll see, I guess, about the auto enrollment. Somebody said cool people like Star Trek. I agree. They really do. Somebody said carriers are going to do a running computation to spread the cost over remaining months. Good luck. Yeah, they definitely will do that. What do we got for questions? So the client is never paying at the pharmacy. They will only get a bill later. Correct. That is correct. Do you know any specifics on how the pharmacist, I think you probably meant pharmacy. Do you know any specifics on how the pharmacy is paid on drugs? Yeah, the out-of-pocket that usually would come from the patient is going to be paid by the carrier. I know it's got to be paid relatively quickly, so they're paid up front. I don't know the exact, I couldn't find details on the exact amount of time the carrier has to pay them, but it's fairly quickly. So everyone pays the deductible, then pays what they would have paid in the donut hole, 25% up to the 2K cap. Well, the 25% phase isn't really the donut hole, it's the copay phase. So that 25%, it will be in the form of copays and coinsurance. So it's different than the donut hole, where in the donut hole is just a straight up 25. It's not now. It's going to be like you're used to when somebody's not in the donut hole and they're in the copay phase, and that's going to be considered the 25% phase. Somebody said, is the 2K max the total of what the client pays and what the drug company pays? No, the 2K max is mostly comprised of what the client pays. Do you see a shift towards MAPD like other FMOs are saying? Yes, 100% I do. I'm going to do a webinar on this, but I definitely will. I think because of not everybody, I mean, some people have the luxury of still staying in a supplement. Now, granted, Medicare Advantage plans aren't going to look great this year either. However, when somebody's drug premium is going up that much, I think you're going to see some people just simply can't afford the increased drug plan and the supplement, so they might be forced to take a good look at Advantage plans. What's your average pricing going to look like? Not sure. Send me a little more detail on that. I'm not really sure on that question. Somebody said at the beginning, yes, it will be difficult, but I think with time it will gradually fall into place. Yeah, I agree. I mean, they'll sort out all the kinks on this, and I don't think, I'll say right on the record, I don't think this is a good thing. I think it's gonna crush the med sub market because of the standalone drug plan prices, and I think you're going to be surprised at how bad it hurts the Advantage plans on the medical side because of this. Are we going to see reduced formularies, and if so, where do members who have non-formulary drugs go? Yeah, you're going to see they're going to reduce the formularies as much as they legally can. Obviously, they've got to have a certain amount of drugs in each therapeutic category, but I think you'll definitely see restricted formularies. Let's see what else we got. MOOP at 2,000, does the 75% plans pay go towards it? No. Do we anticipate this will change? The help beneficiaries can sometimes get directly from the drug maker. That's a great question, and I don't know the answer to that. Yeah, you're right. The pharmaceutical assistance programs right from the manufacturer, will that change anything? I do not know. It's a good question. I don't know that answer. This seems to be another step towards national healthcare, aka socialized medicine. Yes, 100% it does. And we are going down that road, whether we like it, know it, we are going down that road. When you look at right now, there's a little over 50% of Americans are on government subsidized programs between Medicaid, ACA, and Medicare Advantage. Once you see that hit 70, 75, 80%, I think the road will be paved for that to happen. So, yep, completely agree with your statement. How will this play out with medications that are not in formularies? That's going to be more restrictive. I don't think there's any question about that. Back to the Med Sup, has the AARP rate been approved or is it proposed for New York? I have to check. I think it's just still in the proposal phase, but don't quote me on that. I have to double check on that. Okay, so let's see. Somebody said, sorry, I know you said this, but please clarify. They can enroll in the M3P if their drug cost is more than 600. How is eligibility determined? No, they can enroll in MP3 whenever they want. It's the 600 or more that triggers that the pharmacy has to notify them of the program. And with older language, there was talk that it would trigger automatic enrollment. I don't know on that second part if that's going to be in place, but it certainly triggers notifications when they have more than $600 on a medication. How will this affect Medicare savings programs? You know what? I don't think it'll affect it that much because on Medicare savings programs, this is going to reduce their spend tremendously. So probably the reality is they don't have to change anything because they're going to be spending a whole lot less on Medicare savings program now. Let's see. Are you aware of any carriers discontinuing plans in New York? The first look of UHC plans seem to not have a number of the 2024 Advantage plans showing. Yes, across the board, there are carriers. I won't mention them by name. Across the board, you'll need to check this year. There are carriers that will be reducing where they're offering plans, especially the non-dual plans. You have some carriers in New York, especially more like central and upstate though. I have some carriers that are simply going to really this year only be offering dual plans in VA plans. Their non-dual offerings are going to be slim to none. So you're going to see big service area reductions. You're going to see a lot of contraction in the Medicare Advantage market this year. Somebody said, thank you. I appreciate that. Doesn't look like we have any other questions. Again, go on YouTube. You can watch the videos. I've done past ones kind of on some of these topics, but we'll have the recording up there. We will email it out. We're doing our webinar on Thursday at 12 o'clock, and that is going to be on the upgrades for 2025 to Connecture and Sunfire. So I'll be hitting the upgrades quick. Just doing a quick comparison of the two programs. We will be offering those both at no cost again for 2025. So agents won't have any cost to use either platform. They are doing a number of upgrades and various things on those for 2025, and we'll talk about those Thursday at 12. Other than that, it looks like we're done. No other questions. I appreciate everybody coming on. Thank you very much. And if you have any questions, give us a call. Thanks and have a great day.